Okay, we're back. I'm Andrew Quanbeck. I'm an associate professor in the Department of Family Medicine and Community Health here at UW-Madison and a member of the D&I faculty. And this is always one of my favorite days of the year, and really excited that we have awesome guest faculty again, and thanks for setting the stage. We're now going to move into panel discussion where we get to see some sort of real world examples from researchers here at UW-Madison applying some of the concepts that we've talked about. So I'm just going to quickly introduce our speakers. Dr. Randy Brown, his interests, he's an associate professor, or a full professor in the Department of Family Medicine and Community Health. His interests revolve around the treatment and prevention of substance use disorders and related conditions in settings outside of specialist treatment environment. He serves as a consulting physician in addiction medicine at UW Hospital, where he is the director of the Center for Addictive Disorders, the UW HIV/AIDS Comprehensive Care Center, and the UW Multidisciplinary Clinic for alcohol-related liver disease. He's also a founding director of the UW Addiction Medicine Fellowship Program, the director of the Madison VA Interprofessional Advanced Fellowship in Addiction Treatment. And then our second panelist will be Dr. Nasia Safdar. She's the UW-Madison Director of ICTR Investigator-Initiated Multi-Site Research and a Professor of Medicine in the Division of Infectious Disease. She holds affiliate appointments in the Department of Population Health and the Division of Geriatrics, as well as the Division of Industrial Systems Engineering. She's a Vice Chair for Research in the Department of Medicine and the Medical Director of Infection Control at UW Hospital and Clinics. With ICTR, Dr. Safdar serves as both director of the Wisconsin Network for Health Research and the CTSA PI designee for the Midwest Area Research Consortium for Health. So with that, and for the structure of the session, we're going to have two pretty short presentations, kind of back to back, and then there will be a Q&A session. We're going to bring Drs. Kilborn and Elmorel back up here to serve as discussants, and Dr. Brown will be our first panelist presenter, so I'll turn it over to you.
All right, thank you for the introduction, and thanks to folks at the D&I Launchpad for inviting me to be here. Really excited to talk about this line of work we've been involved in for a few years, and that's kind of taking its next steps. I'm a family physician by training as well as addiction medicine, and very early in my primary care training, I developed a lot of curiosity about how muddled we were in healthcare, about how we prevented substance-related issues and how we addressed them in general medical settings. And so I've devoted a lot of my career to that set of issues. And this project really focuses on the population of individuals who have sustained a traumatic injury of a level of severity that requires hospitalization. And that represents a seminal event predictive of exposure to opioids and then potentially opioid misuse and the development of opioid use disorder. And we really know very little about that trajectory and where we might intervene. So the guidelines that are out there around prescribing are really pretty squarely focused on chronic pain. And when you look in the literature around trauma, there's really very little out there about, what happens after injury, who might be at risk for developing problems controlling their use of these substances. And in my clinical work, I'm at UW Hospital, you see there, and I consult on patients in the hospital who have been admitted for any number of variety of conditions, but substance use may be complicating their stay or may have contributed to it. And I remember one day, a nurse practitioner on the trauma service came up to me and said, "Dr. Brown, I'm really worried that we're getting people addicted to the pain pills that we're prescribing." And I thought, I wonder if that's happening. And if so, I wonder who's at risk there. And so the initial study we undertook that was funded intramurally here was to follow a group of 295 individuals forward prospectively for 6 months, collected a variety of validated measures at baseline around demographics, mental health, substance use, collected some measures going forward around their pain, how they're managing it, and looked at final outcomes 6 months out around, are they misusing their opioids or have they become addicted to their opioids? And things on these analyses that showed some signal were around anxiety-related symptoms that were pre-existing prior to their trauma, and pain coping, more specifically what we refer to as instrumental coping, versus the opposite, instrumental coping referring to sort of constructive adaptive strategies around pain. So progressive muscle relaxation, meditation, where maladaptive might be, I don't know, drinking tequila and yelling at your family. And when those adaptive strategies are present, it was less likely. And you can see some fairly strong prediction here based on this prospective study for misuse and use disorder at 6 months. And so we started to think, so where do we take this? Let's see. So, well, yeah, looks like we know some things about what we should look for. So now I know that I should monitor folks for these things. But, well, what do we really do with that? I mean, the group of people who have been traumatically injured vary a lot in terms of their personal history, demographics, things that might confer risk for opioid use disorder. So we don't want to throw the Cadillac of pain coping strategies, care coordination at all comers. Not everybody needs that, right? So we need an adaptive intervention. So what we started considering was an adaptive intervention, and a lot of cooks have been in this kitchen, and I want to really quickly thank Dr. Ben Zarzer. He's a trauma surgeon here, has been looking at kind of enhanced care coordination models after traumatic injury that inform some of this work. Tammy Summers at Duke University, who does a lot of work with pain coping strategies training. And methodologically, lots of wonderful advice from Dr. Almerel and Dr. Quanbeck, who's been involved in some of this work from the beginning too. So lots of wonderful people going to work on this. And so you can see sort of based on our work and some of the work that Dr. Zarzer has been doing with care coordination, we started to think maybe this is how care should look after a traumatic injury. We're able to sort out who might be at risk. We pay closer attention to their care in some ways. Then we reassess down the road. Not everyone's going to have the same trajectory after that point. And so maybe that needs to be adjusted at some point, say 4 weeks out from that injury. But great idea, but there are a lot of questions to answer before we can really fine-tune that and optimize it. So these are some of the things that we're planning to take a look at by way of questions. What's the impact of starting sort of a more enhanced intervention that Dr. Zarzer in his work was referred to as trauma medical home, that basically involved bi-weekly contact, some standardized instruments that guided clinical decision rules around strategies attacking, say, depression or anxiety, functional status, sleep, things like that. How do we decide who gets what of those interventions, and how do we adjust potentially if their course is not going the right direction at 4 weeks? And so this is the rough design that we are settling on at the current time for the next study. So you can see we have an initial 2x2 randomization, and what you see by way of TCC is to standard trauma care coordination versus enhanced. And then the other condition is pain coping skills training versus no. And then you see after that initial randomization reassessment at week 4, and then we're assessing for risk around opioid misuse with a couple validated measures, current opioid misuse measure and the pain catastrophizing scale. And then for those that greater than minimal risk, we're re-randomizing to either staying the course or augmenting treatment. And so this is kind of a fuller demonstration of what that design looks like. So again, this is a pilot, and as such, the aims are pilot in their scope. So we're going to be looking at feasibility, acceptability, predominantly, and hopefully gathering some preliminary data to guide the NIH study. But we're really going to be looking recruitment, acceptability of the intervention through validated measure, and really the core of all this, moving toward larger funded study, is manualizing aspects that have been talked about earlier this morning, the clinical intervention itself, how we're implementing that, as well as those logistics with the study as well. So, and I finished on time, apparently. All right.
All right, and please do write down your questions and hold them, and we will have those after we hear from Dr. Safdar.
Thank you so much. Good morning, everyone. What a fabulous conference this is. I've been coming to these for a few years, and each time I figured out some things that I was doing wrong that I shouldn't have been doing. It's too late to fix the slides now, so you'll just have to bear with me. Don't ask me questions I can't answer. So our work has focused really on antimicrobial stewardship and infection control. And the good thing there is that there are lots of best practices, evidence-based interventions that one could take to the next level. The bad news is that not many of them have been subjected to the sort of rigorous implementation work that chronic diseases have. And there's a lot of room for effort and growth in this area. A classic example that I've never forgotten when it pertains to infection control is that we were trying to reduce the rates of some infection. I think it was C. diff. This is many years ago. And we had developed an intervention, and we thought that we were doing a really good job in the intervention, and the rates of C. diff went down. But when we went back and looked at it, it turned out that the intervention had never been implemented in the first place. So just to show you the importance of implementation when it comes to figuring out what actually is happening. So C. diff is something that we've been working on for about 2 decades at this point. Still about 500,000 cases in the US yearly, lots of excess cost. The biggest thing to me is that sort of the unfairness of it. You know, a patient comes into the hospital with another condition only to leave with C. diff. That just doesn't seem right, particularly when the infection is largely preventable in the vast majority of instances. And how do we prevent C. diff? Well, there's 2 aspects to it. One is infection prevention, which is putting people who have C. diff in isolation such that healthcare workers will wear gowns and gloves when they go into the room, something that if you visit a health system, you will see plenty of. But the other equally important thing is antibiotic stewardship, because C. diff is a disease of gut microbiome dysbiosis, and it's the antibiotics that are causing the problem with the gut microbiota and therefore making us vulnerable to C. diff. So reducing broad spectrum antibiotic use is a key tenet of antimicrobial stewardship, and that would reduce about 1/4 of inpatient-related Clostridium difficile infection. Now, when we talk about antibiotics, it's a very large group, so we can't reduce all of them, at least not all at the same time. So which are the ones that we should focus on as the targets of our stewardship? And a key one that we noticed in our own health system was fluoroquinolones. Infectious diseases, well, not just ID, everyone loves fluoroquinolones. They're oral, they're convenient, but they're also at a really high risk for causing C. diff. So we wanted to see what we could do about reducing fluoroquinolones in our health system. We had a culture where fluoroquinolone use was deeply entrenched. It was the workhorse of everything that we did in terms of treatment and sometimes prophylaxis. So we know that pre-prescription authorization, antibiotic stewardship interventions can reduce C. diff. The question was how to best implement them. And the reason why this pre-prescription authorization piece is important is because you can do it one of 2 ways. You know, you can let people prescribe what they will, and you can give audit and feedback after. The problem with that is that the damage has already been done. And so the prescription has already been filled, the patient's already taken it. When you do upstream stewardship, which is that you limit the prescribing in the first place, that's bound to be more powerful for reducing C. diff. It's also much harder to do, which is why it hadn't been done for all this time. So we started out with, you know, I'm distilling the work of several people, several groups, and several months into a single slide. But essentially, the consensus was that we should do a pilot study in our own health system first and see if we're able to come to a point where we can reduce fluoroquinolones. And some very legitimate concerns were raised by people, which was that, well, what else would we use if we weren't using fluoroquinolones? And were we going to see poor patient outcomes as a consequence? Because some of the substitute anti-infectives may have side effects that fluoroquinolones didn't have. Also, healthcare workers sometimes are very insulated from the full cost of antimicrobial treatment, because a patient might go home and then get C. diff, and I would never know, even if I had been the prescriber that gave the fluoroquinolone. So in this pilot study, this was in 2 ICUs. We focused on the ICUs because that's where our greatest burden of C. diff was. And we found that there was a massive reduction in the days of therapy per 1,000 patient days for both the solid organ transplant unit as well as for the ICUs. There was also a little bit of decline in the non-intervention units, probably because of diffusion of intervention, since it was the same trainees and physicians that went from unit to unit. So that was the intermediate outcome. Could we reduce fluoroquinolones? And then the other was, could we also reduce C. diff as a result, which was the clinical outcome? And as you can see there, from the pre to the post intervention, there was quite a large decline in C. diff, which led us to think that this is an intervention that we should then see if we could implement in other health systems and disseminate, which led to this AHRQ-funded R01 study, which was looking at multi-site implementation effectiveness of this intervention that we had done of fluoroquinolone pre-prescribing reduction. One of the things you'll notice I didn't mention in our pilot was doing a deep dive into the implementation aspects of it. We were so focused on reducing our C. diff rates, we didn't really even think about, well, if we're implementing this intervention, what impact is it going to have on the provider and their workload? What impact it's going to have on the nursing staff and their workload? So those were all the things that we built into this larger study, because without that, even if you can sort of by sheer force of will push an intervention into a health system, it's not likely to be sustained unless you address those things preemptively, as we all know. So this was the inclusion criteria. We wanted this to be an intervention that could be implemented within the EHR, because that was the usual pathway for prescribing anti-infectives. And so we had to have a health system that was willing and interested and enthusiastic. Numbers go down as you keep adding the criteria. That wanted to, in short, that wanted to make the change to the EHR. And they couldn't have any pre-existing fluoroquinolone EHR restrictions, which was not a hard thing because many of them hadn't arrived at that point yet. And we needed to provide the support around this intervention such that you can imagine the frustration of a prescriber. You go in to prescribe a fluoroquinolone in the EHR. There's a hard stop that comes up that says, well, you can't prescribe this one. So there you stop. So what is a provider to do? You have to provide them with the support to call a pharmacist or an ID physician or someone that will give them an alternative. And so that's what we asked the sites to do. And then the ability to extract the data from the EHR. So these are the sites that we've included so far. A lot of this work happened deep in the depths of the pandemic. So kudos to these health systems for still doing the work and being able to think about stewardship while they were struggling with COVID. But as you can see, a number of them have completed the intervention. Some are still active and continuing. And these are some of the study site features. The type of facility varies, the geographic location, we wanted to be as spread out as we could. Most of them are academic, although there have been some community hospitals that have expressed interest. And the difference really is not so much that they weren't interested, but they weren't able to have the infrastructure that would allow them to make these changes to the EHR. They're often tied to larger health systems, and they had their own strategic plan for when they would update or change their EHR. And you can see the diversity in the ICU beds, and so on. And these are the things that we collected information on, both for the intervention as well as for the implementation. So we had regular check-in meetings where we systemized data collection. We had questionnaires to assess both infection control and antibiotic stewardship at each site. And then we wanted to look at the specifics of this hard stop about the best practice alert or the BPA. How often was it firing? Who was setting it off? What were the consequences of overriding it if people were allowed to do that? And one of the things, as has been discussed already pretty exhaustively today, is that you have to be flexible to be able to adapt the intervention to the community or the setting that you're trying to implement it in. And one of the first things that came up was that people said, well, we don't have a 24-hour ID physician that's going to be willing to take calls on stewardship. So can we change that to say that a trained pharmacist could perform that role who are on site and are interested and willing? And so it was those kinds of adaptations that we collected data on so that we could see what the core was and what could be changed in the future. So our preliminary findings are that days of therapy for fluoroquinolone have decreased at all sites over the duration of the intervention, but it varied with COVID surges, as you might expect. And this is what the fluoroquinolone prescribing trend lines have been. You can see that for this site, their usage was already going down even before the intervention was put in place, but the acceleration of the decline was much more once we had the BPA put into place. And this is, again, the same thing, monthly ICU fluoroquinolone days of therapy, very few in the intervention period, a lot higher in the pre-intervention period. Another site showing the same thing. So the effect seems to be consistent, and now we're collecting data on the implementation aspects of it. And these are the types of fluoroquinolones that were reduced over time. So we used CFIR as our framework, and what we found was that there were some significant facilitators that were important here. The biggest thing, I think, for us is the organizational factors, where the site had to be willing to, as some of you have already heard, that the site has to be willing to make a standard of care. It's a best practice. We should be doing this. And then we came and helped them implement it and then collect data on the implementation. The significant barriers were leadership turnover and therefore lack of engagement. And then we're documenting this using the various frameworks that are listed there, in addition to documenting the adaptations so that we can have a toolkit that would say, if you would rather do it this way, this would still work, but these are the things that need to be put into place. And to add to this, we're very fortunate that the VA has funded what's called a query partnered evaluation, which has allowed us to create a survey to ask specifically about antibiotic stewardship practices during the time of COVID. Because as I said, many of these sites implemented this during COVID. So this will be deployed to all VA facilities, and we expect to find increased use of anti-infectives for respiratory conditions. But I wonder whether we will find more fluoroquinolone use or not. I suspect we won't, because I think that's been baked into practice now. Just want to thank all of the key personnel, our funding agencies, for all the hard work. It really took a village to get this implementation study going. Thank you so much for your time and your attention.
Okay. Well, thanks to both of our panelists. We'd like to invite Dr. Hilborn and Dr. Elmerl come on up to the stage and have a seat. And I think first we would like to have the two of you just kind of reflect upon what you heard from our panelists, and then we want to get questions from the audience as well. So we have until 12:15 for this, and so yeah. I don't know if Danny or Amy, if either one of you wants to go first and just kind of reflect upon what you heard.
My question on how do you say it? Fluoroquinolone? Quinolones is the study that you're working on right now. Is it a pilot study? Is it a randomized trial? You were showing us the pre-post, which made me think that you're in piloting phase, but maybe not. Can you walk me through that a little bit?
Yeah, no, it started out as us wanting to do a randomized study, looking at two different types of stewardship intervention. And it turned out when we included the sites in there, they said, well, we don't really want to be randomized to one or the other. We want to do this one that has been shown to be best practice. So it became a step wedge, and so that's what we're doing now. Just the pre-prescription authorization. So not a pilot.
That's great. And then Randy, it seems like yours is a pilot, solidly a pilot, correct?
Yes, very much.
And earlier today, David Horton had asked, when Amy was talking, a question about, well, how do we publish the results of pilots? And I just wanted to say one thing about that, and then I'll turn it over to Amy. I think you guys have an incredible opportunity when you're publishing the results of pilots, because the cool thing about a pilot is you get to tell the world, these are the 100 things I think are going to go wrong. You do the pilot, and then you report which one of them went wrong, how did you fix it, and what went wrong that you didn't even anticipate. And how'd you fix that? And that is a really important paper because you don't want anything to go wrong when you're doing the trial itself. And so, and then I'll say one more thing. The other thing, output you want out of a pilot is you want to walk away with 3 manuals. Number 1, your intervention manual. Number 2, your implementation strategy manual. And number 3, how are you going to mount the full-scale trial that you're going to do next? And notice that nothing I said there had anything to do with preliminary effectiveness, David. So I just wanted to get some thoughts from you on that. Does that sound like something you'll be doing? Does it sound interesting? Did I miss the boat? What are your thoughts on what you might get out of a pilot? I think they're cool.
So yeah, I think that's a really great series of questions. And I would add too, one of the questions I had for both of you was, what does your implementation strategy look like from the perspective of people receiving it? So, for example, I think systems engineering is a really powerful tool to get things done right in clinics. And one of the challenges we have in VA is, for example, that when we are trying to promote practice change and we say we want to use something like systems engineering, we usually have it come out saying, gee, we're going to use lean to improve your system. And a lot of VA frontline providers will just laugh in your face and kind of show you the door. And that's not because it's a bad idea, but they've been through the ringer where they've been in situations where they've gotten a kind of implementation strategy like lean, and it's not been the real lean, it's been fake lean, meaning that it was imposed upon them, and it wasn't the bottom-up empowering frontline provider look. So I'm just curious, just as with lean, I would be curious about what systems engineering approaches look like and how we would try to, use a term again, manualize them so that they can be replicated. I think that's an understudied and exciting area of implementation research.
So we use the Systems Engineering Initiative for Patient Safety that was developed here many years ago, which has allowed us to think holistically about the system, meaning so the organization, the person, the tools, tasks, and technologies. And it has also allowed us to anticipate, as you said, what things could go wrong. Not that you can always predict everything, but as a classic example was, when we were trying to figure out which antibiotic to pick to focus our stewardship efforts on, these questions that came up was, what are the alternatives, and are the alternatives potentially going to be worse than the one that you're trying to prevent? And so how do you address that adequately by collecting data and showing people what it did and didn't do during the pilot? But that systematic approach, I think, is often missing in a lot of stewardship interventions. And so we're hoping to change that by systematizing who to interview, what questions to ask them, in addition to sort of the core stakeholders you would think, you think of 5 more that would be impacted that you haven't thought about. So that's been one approach we've taken.
And from the standpoint of our project, we're in that really fascinating span of time where we just heard that our application was funded, right? And so you, within the last couple of months, right? And so you have somewhat more limited space in the context of your funding application to unpack all that. So it's wonderful to be here and be able to interact with you all, because we're right now kind of in that very active thought process around how is this all specifically getting operationalized? What's the clinical intervention going to look like? And getting those ideas developed. I mean, I think one thing I'd throw out, just an example of some of the discussions that we've been having on that front. This is going to be a study at 2 sites, one in Milwaukee, a level 1 trauma center, and one here. And so we've been thinking, okay, with that care coordination intervention, we initially thought, oh, we'll just centralize that. Like that'll be out of, University of Wisconsin. And then as we sorted out workflow at each of the sites, it turned out that was just impossible, and that we need boots on the ground like both places. And so we're really taking advantage kind of this stage, really interacting with the key stakeholders, the nursing staff, the trauma surgeons, and really doing our best to get those ducks in a row and make sure that from their standpoint, they feel like this is doable to some extent. And then there's going to be a qualitative component to the study where we're going to do a little more investigating from the patient perspective and just get a best sense of, what aspects of this intervention were appealing and what would you rather not. And I really appreciate sort of your comment around what the preliminary paper could look like, because that also just strikes me as so much greater use to the field than this is what the outcomes were, to replicate the study and help someone else out once. So,
That's great, Randy. Nasia, Dr. Safdar, one of the things I loved about you presented, and I want to kind of elevate it a little bit, is you were essentially doing a version of what some people call, and I cringe when I hear this, de-implementation. I don't actually like the term, and I'm glad you didn't use it. I really don't. It just feels icky, like, oh, you want to de-implement me. But you are doing a version of that, and what I love though is that it was so real. Like you're trying to take something away, but then you're explaining what you can do. That's like meeting people where they are. And it's so real. I can't tell you how many times I see interventions or strategies where we're just going to show up and we're going to do these 100 things, but their time is limited. They have the same amount of time. So can you comment on that?
Yes, this was, we used the Cotter change model to figure out how we would actually move forward with this pilot when we were determining it. Led to a lot of meetings. It helped that the chief medical officer came and gave us a charge to do the intervention in the health system, which sort of then made everybody feel, yes, it's very important, we should do it. And then thinking about what would it take for you to be comfortable with this? And when people said, well, I don't know, we've been doing this for a long time, there's a lot of history in this institution, the only way that you can counter that is to say, what would make you feel comfortable with this? And then whatever they say, you get as close to it as you can.
I could maybe offer a couple of thoughts on Amy's comment about systems engineering applications and implementation science. I mean, there's all kinds of possibilities. Systems engineering is a very, very broad field. And kind of one of the things that I often say is that, we don't want to get into the habit of, when you have a hammer, every problem looks like a nail, because there's, I think, different approaches that are needed for different problems. Some of the things that I'm doing in my research alongside with Danny and Randy and others is sort of always including the idea of cost effectiveness analysis. And I think of that as an optimization kind of approach, because we reach a point where if you have something is workable or successful, it's going to come down to a decision maker saying like, well, we have to balance all of these other things that we could do. And so how would we allocate budget? Is it worth allocating budget to this particular activity? I mean, cost effectiveness is just really part and parcel to all engineering kind of approaches to design, systems design, intervention design. Another area that I'm really interested in is agent-based modeling, other types of simulation modeling. Lindsay Zimmerman from the VA in Palo Alto and at Stanford is working on using systems dynamics modeling as an implementation strategy in itself. And I think the idea there is kind of building an accurate representation of, whatever system that you're trying to intervene upon, so that stakeholders working within the system can sort of, like, well, what if we added some resources here? What if we did this thing differently? And then, see what the likely effect would be before trying things out, which I think provides some opportunity to implement more efficiently and effectively, because, you don't have to go through a whole 5-year study if you can figure out that it's probably not going to work by simulating it first.
So that's a really great point to make, and it got me thinking on another angle. I won't say the D word, the de-implementation word. Oh no, but I want to riff off of what Nasia, you were talking about earlier about that, because it's really almost like you're talking about substitution of another behavior. So if anything, it's really it really is time having the providers do an intervention. They're just not doing the old intervention and doing a new intervention. And so one thing I thought about in combining the kind of thinking of both your of your research is an example we did in Query because we had to. So Query is their VA Quality Enhancement Research Initiative, and several years ago, I'll give you a long story short, which is we're funded by clinical dollars in a VA, meaning that we have to do everything we do has to be for the clinical quality improvement for veterans. And several years ago, that funding was threatened because at the time there was a budget shortfall in VA and they needed the money to pay for services and not quality improvement. But we made the case by basically designing a new type of study that our Query investigators could work on that basically involved using an implementation strategy or set of strategies to implement an effective intervention to move the needle on a quality indicator that was at the essentially that the medical center directors were responsible for improving. So we paid the study to basically determine if they actually improve quality of care. And the largest study that was funded in this space was on opioid and pain management. So we were at the time rapidly trying to reduce the number of opioid prescriptions among veterans, but the idea was also getting pushback because many politicians were worried that cancer patients were not getting their opioids, and then also veterans who were in a lot of pain who may have needed something were not getting something else for their pain, right? So the idea was the substitution. It wasn't a de-implementation study. It was actually a study to implement alternative pain treatments, not all complementary alternative medicine necessarily, but rehabilitation therapy, CBT, things like that. So they had a slew of evidence-based pain interventions to substitute the opioids that they then provided to different settings. And in doing so, they not only moved the needle on reducing opioid prescribing, but they also improved patient satisfaction scores, which were tightly linked to pain scores at the time. So if you think about de-implementation really being more about substitution and thinking about ways in which you can also move the needle on quality indicators, that could be a really valuable and important way of getting buy-in to the implementation work you're doing.
I wanted to shift gears a little bit, if it's okay.
Yeah.
Dr. Safdar, you use technology as part of your implementation strategy, almost because you have to, right? People are interfacing with the EHR. My question to you is, could you tell us a little bit about challenges and successes there? I suspect that wasn't easy. And then I have a similar question for Randy. Randy, you are trying to intervene on people in their lives after hospital discharge. They're no longer in your realm. There's not even, and so is technology, can it be a part of this intervention that you're creating? Do you think it might be? Do you anticipate challenges or successes there? So it's more like a technology question.
Sure. Yeah, so the technology challenges were probably the single biggest issue with this trial, is because, and I think to your point, about if it's something that the health system already wants to implement and you're helping facilitate the process, that went over really well, as opposed to here's a research question that we'd like you to answer, and why don't you switch out your entire EHR for us to do that? That didn't go over so well. So once we sort of figured out the engagement and the enthusiasm of the health system, and then we coached them and facilitated it, that was really the only way to do it. We still came up across challenges that could not probably have been prevented, which had to do with the timeline of EHR when changes could be made, and that all went awry because of COVID. And then the resources. There was so much workforce burnout and staff shortages that people just didn't have the IT staff to be able to make those changes. So we were fortunate in our own health system. We had a very strong pharmacy department that got very excited about it and was a partner with us in stewardship and was able to do it. But some of the systems that originally committed to it then had to say they couldn't simply because they weren't able to do it.
From my perspective, I think in our health system, this has evolved so much just within the last 5 years. I mean, we've been on a number of studies where we had high hopes for integrating a mobile health intervention to Epic, and it was just flat no out of the gate.
Mm-hmm.
But I mean, the electronic health record has evolved, insurance that involved it has evolved, where I think some possibilities that didn't exist before have come around. The ideal, of course, would be, we're going to be doing serial assessments, and we're going to be doing assessments that then trigger randomization. Would be wonderful if that all could be seamlessly integrated into Epic, the electronic health record. no way that's happening. They haven't evolved quite that far. But there's functionality that wasn't there just those few years ago called MyChart, where messages can get pushed out to patients and you can provide a link to a survey there. And then that's integrated into the nurse care manager's workflow so that they can then get those survey results. So they're not having to go to an entirely other website or location to get that information anyway, which is key, with busy clinical providers. So.
I might pose one more question to the discussants and panelists, and then we'll want to hear your questions in the audience. So we've heard these stats, and you can argue if they're accurate or not, but 17 years on average for 14% of evidence-based practices to be implemented. And so I think there's two important components to that mathematical statement, the 17-year part and the 14% part. And I think they kind of go together. And I'm just wondering if you want to reflect on, how the types of approaches that we've been talking about this morning can, number one, shorten the time, and then possibly number two, also help us better select and choose the right interventions to be putting our implementation resources behind.
I'll just throw out the cynical view right away. It's all about the money, right? So, that's to your earlier point, integrating cost effectiveness outcomes into trials can go, a long way, having some demonstration to systems that the intervention you propose isn't going to be unduly burdensome, isn't going to impact their bottom line horribly. And that's where I think, these adaptive interventions really come in, and precision medicine and getting these interventions more well-tailored to folks and the folks that really need them.
Absolutely. I think the other part too, complementary to that is, there's an opportunity. So you're all part of a CTSA and we're representing our CTSA here. There is, I think, a dearth of funding to actually pay for the real research that needs to happen to get to a better place where we are more rapidly and effectively translating stuff into practice. And I think it's been a slow but incremental, but it's getting there, movement in NIH to fund more implementation research and to do more phased awards where you have the time to think about, essentially getting your manuals written, validating your measures, making sure things work, and matching your barrier to your implementation strategy to have that fully formed implementation trial. But it's going to take more, and I would highly encourage the CTSA here to respond to the public comment period of the NCATS, which is the people who fund the CTSA's new strategic plan, which actually says up front, we want to get treatments to all people faster. I mean, they're saying it, at least saying that they want to do that. But when I looked at the actual specific goals, they seem a lot more focused on the kind of this, I still see the bench to bedside language and not the bedside to community language. And so if you could maybe respond collectively to those strategic goals in the open comment period, which is now until mid-November, that would be great. I mean, we're doing a collective response to that through MISHR, our Michigan CTSA, and I highly encourage you to do that as well. I think the more they hear, the better. I don't think that we're necessarily going to, sort of get rid of the traditional clinical trial R01 type mechanism, but what we can do is at least try to get some of the NIH funding agencies to tilt towards more doing T3, T4, what we've called translational research on the implementation side of things.
I'll maybe just add that I think for us at least, it had to get to a point where the status quo became untenable. And so however we can get to that point, and for us it was any lever that needed to be pulled was pulled. So for instance, part of it was, yes, stewardship needed to step up and say how critical this was, but they had been doing that for a long time. Patients needed to step up and say how important it was that they got C. diff and the quality of life, and that had been done. But the thing that really changed eventually was that legislation came about that said that healthcare systems would have to pay a financial penalty unless they reduce their rates of C. diff. And so all those other things did get us part way, but the thing that took us over that was, as you said, the money and the incentive and the disincentive in some instances really does make a huge difference.
On the 17-year, 14% thing, Well, I think you heard a little bit about my take on that. I think we're in a tough position right now because implementation scientists are eager to implement, rightly so, but they're implementing interventions that are not real world. And so we need to do that, but we also need to double down, I think, on our really good optimized interventions, which this can be done, y'all. Speaking of engineering, this all comes from engineering. The idea that, like, I can say, these are the constraints. I want to spend X dollars. I want it to be X minutes. You can get input from whoever payer is to tell you what those constraints, what they think they're going to be in like X years. And we can engineer a really good intervention to meet those constraints. It is all about the money. But right now, it's this funny little thing where it's all about the money, but then we hit the money wall later without proactively thinking about it ahead of time. And it all just seems a little backwards. And so I think that you've heard today some ideas on how we can cut back to 17 from many different angles.
All right, well, I want to turn it over to questions from the audience.
And while we're making that pivot super quick, sorry to bust in, but I was remiss in my thanks in not thanking David Horton, who is out there today. He's a researcher in our lab, and he's been a huge, huge help on the project and thinking about it and moving us toward implementation. So.
Yeah, Dr. Lucy.
Well, I have a question that has come from Randy's presentation, and it has two parts. The first is, Randy, in your study, who is the study subject? Is it the provider of care or the recipient of care? So, and based on that, then, how do you power an adaptive study so that it meets the criteria of the funding agencies?
So the primary outcomes are going to be patient-oriented. So development of opioid misuse, opioid use disorder. In the context of the pilot in particular, however, there is going to be qualitative data collection from providers as well as patients, again, digging a bit into feasibility and acceptability from each of those perspectives. And so right now at this stage, we're not overly concerned about power because the things that we're going to be reporting on are again, sort of those feasibility, acceptability, and now that I've gotten the idea from Danny, sort of the problems that we encounter and how we handle them. And then I think, going forward, ideally, yeah, once we have all this done, we'll have some preliminary, outcomes from the patient level that'll lend support to that larger study that will have, appropriate data for guiding that sample size analysis.
So just to augment on that, and then I'll be quick. Randy's study is a patient-facing intervention, okay? It's the person who got discharged from the hospital after being in the hospital 7, 14, 30 days due to injury. He's developing that pro. So that's the first answer to your question. And then Randy's right. He's doing a pilot first. So there is no power for effectiveness. It's sample size for doing the feasibility work. However, what's really cool about pilots, I don't know if you guys have ever thought about this, is a really well-designed pilot actually conducts the sample size calculation for the full-scale trial. And Randy did that. I know your biostatistician did it because I was in communication with them. And the reason you do that is so that during the pilot, one of the things you're also piloting in addition to the intervention is your ability as a research team to recruit the right number of people. So when you do the full-scale trial, you're able to mount it. So pilots are really good for learning how to be a good researcher and really good for learning how to create a good intervention. I hope that helps.
So this is for anybody on the panel. As you think forwardly about the shift, hopefully, in funding for the T3, T4 world, when we think about the skill set, you all are expertly trained, very technical, the skill set needed to do these implementations, how are people going to train who are in the position of leadership? Because we have a lot of people who are leading a lot of organizations who are outside of academia, who don't have the skills to do the work that you all are suggesting needs to be done in order to improve health outcomes. So how do we create that piece ahead of time so that people can start training, so when the funding shifts, we can actually get this work done?
That's an excellent question, and I'll try to answer it to the best of my ability, and hopefully the talk I give tomorrow will dive into it a bit more, because training is really so important to the work we do, because I didn't learn any of this stuff in PhD school about how to talk to people, understand what the issues were, to basically design and figure out what kind of study to do and recruit sites to have enough sites in your cluster randomized trial of blah, blah, blah. I'll say, just from the standpoint of researchers who are getting prepared, maybe in an academic health center, or they're in a graduate program and they want to do implementation research, I'll start with that. I would say what's been really enlightening have been the Agency for Healthcare Research and Quality core competencies of learning health systems work, because they basically cover training and everything from improvement implementation science to how to actually ask for data from an EHR, to how to actually have those conversations with leadership, and also how to have conversations and empower community members who would like to participate or be actively involved in a type of study. So it's very multidisciplinary. It kind of covers the gamut of the different types of skills to have. If I were a practitioner or a community member or someone just living in a community and was interested in using more research, or even being a researcher myself, then I would want to be able to get some basic knowledge about, and not just basic, but just knowledge about basically how do I articulate the common sense and wisdom I have from the experiences I have had, to talk to researchers who are in a position to get research dollars to do things that would be most appropriate and helpful for my community. So I think that would probably take some effort, where we have a lot more initiatives through, let's say, medical schools and academic health systems and universities to be able to do like day-long, like mini med school trainings or mini trainings in public health, and how to understand a research paper when they talk about a p-value. It's like, I'm talking a little like these trite things, but I think people in this country are beginning to get a lot more aware of, sometimes when something gets published, for example, it may not necessarily be the truth, and a lot of times you publish and, oh my gosh, there might be something that you publish on a study and it's not generalizable to the community I work in. So I think there's been a lot more skepticism, and you can say it's from all different sides about science in general, but I would say let's ride with it and then actually figure out what is driving that skepticism in research, and figure out and talk to people about essentially what's your concern here, and provide an opportunity to educate about essentially what does good science look like.
Is it okay if I try as well?
Oh, yeah.
I really love that question, and I hope I'm going to answer from a particular angle. I don't know if it's what you were thinking, but as I think about training and the next, in my mind, there's two. There's the researchers that need to be trained up. And let me speak to that one first. So I'm a statistician, right? I'm not a clinician. I'm not an implementer. And in our lab, in our center, the motto is give it away for free. And try to get it into the hands of all researchers. So we have a really strong, what I call, research equity mission, which is we want to level the playing field so that all researchers can adopt these methods. So we're doing that the best we know how on the research side. So that would be like our approach to try to train researchers. On the other side, I think we're all in this really cool space, you guys. Everyone on here, and up there on the podium, and JD, this is a whole new area, implementation science, but that's the science. Who are they doing the science for? They're not doing it for the clinician. They're not developing strategies for the clinician. They're not developing strategies for the patient, even though it's going to benefit them. Guys, what's coming is we're going to need an entire industry of purveyors, of implementers. I'm just a scientist. Amy's a scientist. Randy, we're all scientists. All we do is we get paid for curiosity and to answer questions. When we're done developing the implementation strategy, whose hands are you going to put it into? an implementer. Well, to answer your question, are we starting to think about that? Are hospitals thinking about hiring implementation units? And I only know of one implementation purveyor that just peeled off from the University of Michigan and is now a nonprofit. And that is what they're doing all day, every day. And it's somebody that Amy and I worked with called Trails. So just it's food for thought. It's something for y'all to think about. That is coming by definition because we're doing this science. So I think it's kind of cool.
Yeah, and we here at UW we have the Implementation Science and Community Health Outcomes Certificate program. So I think that kind of gets to be a researcher. I think that that would be the type of resource. I mean, this is a big issue in the field. We all see it, the capacity to do implementation research. It's not there yet. We're trying to build it. And then I agree with Danny as well that the implementers and purveyors, that's really a resource intensive job, but we need to have more of a pipeline for that. And I think of I have an undergraduate degree in industrial and systems engineering, and back in 1998, when I was doing my junior design course, the text that we learned was our course text was Rogers' Diffusion of Innovations. So we talk of this as being a new field, but health systems engineers at UW have been thinking about this type of stuff for a long time. So I think potentially finding people who have the basic kind of skills training and systems engineering, health systems engineering might be a place to look here at UW, and there's other programs in the country that are doing it. Another question? Yeah.
Yes, thank you. So my question is statistical in nature. I'm not a statistician, so with regard to the study design, the adaptation model where you have all these different permutations, would that require a large sample in order to power having enough participants in each of those boxes that are on the right-hand side of those tables? And how do you fund that?
You must be referring to the type of research design Randy was using, is that right?
That is correct, and also in Amy's paper. Yes, thank you.
Oh, yes. The answer is not necessarily. It does not necessarily require more sample size, but it could. And so sample size is this funny thing. It depends on your question. It depends on what effects you want to be able to detect, and so on and so forth. So I can't give you an answer that covers all those bases. But the short answer is, have no anxiety. We have the sample size formulas, so they exist, and more are coming. And B, you're not necessarily going to need more sample size, but you might.
Hi. So my question, I guess the seed of this was Danny's aversion to the D word. So I wonder if there's opportunities there, right? I'm thinking about that statistic that Andrew, you mentioned about the 17 years, 14%. I think there's a converse there, right? That there's a lot of stuff that gets done in medicine, and just because of inertia, we continue to do it. Maybe we don't have the evidence basis for it. Maybe that needs to be de-implemented. And maybe we don't phrase it as de-implementation, we phrase it as improvement. But in a way, there's elements to both what Nasia said as well as what Randy described, which is let's not overdo a certain thing, or let's be smarter about how we do certain things. I just wonder if that would be sort of a great opportunity, because if you marry that with cost effectiveness, the cost benefit calculations, sometimes it's not about sort of growing the pie and competing for more of that 20% of our economy. Maybe it's, can we defund that X%, I don't know what it is, that just doesn't seem to work. I hope we have public policy folks here.
No, I think that's a great question. Several years ago, I don't remember which group it was, and I know someone knows this, but do you remember Choosing Wisely? So that's been around for a while, and the idea was it wasn't de-implementing something, it was basically empowering people to be able to make wise choices about essentially the time and cost it might be for a patient to get certain healthcare services, and some of them were low value, and essentially it was a way of being able to it kind of gave language and agency to providers and patients alike to not do something. And so that's one way of thinking about it is to reframe it. But I think that's a whole challenging area of research, and there's not enough in terms of understanding what it would take to change provider behavior and to change these things. I think there's also there are also cottage industries and advocacy groups that are centered around certain treatments that are also considered low value, and you're going to have to deal with those too. So oftentimes what people may do is actually just substitute and again, but a lot of it is in diffusion of innovations. Much of it is sort of the validity and the value of something you're trying to implement or change. But on the other part of the diffusion of innovations has always been the marketing part of it and how you actually do that, because I think in many respects it's always been a challenge in public health, especially to be able to communicate most effectively what you're trying to do. So more to follow.
I think the other thing I'd throw out as a clinical care provider is I think folks tend to grossly overestimate the extent to which physician behavior is firmly rooted in an evidence base a lot of the time. And there's so much development that is needed on so many fronts. I mean, you think about a few classic examples in medicine. We used to think it was, well, and this needle seems to be moving again now too, so there's that. But we used to think, for example, that postmenopausal hormone replacement was something everyone should get. The right studies weren't out there yet. Similarly, we thought giving high flow oxygen to prematurely born infants was a great idea. Antibiotic courses. How much research has been done that tells us we should be giving people 7 days of Keflex for that cellulitis, right? Like, there's a lot that we do that there's just this ocean of stuff that could be de-implemented, but we just don't know how, because the right evidence isn't out there yet.
And I think some of it is, people have to choose between, because the effort to de-implement something has to be proportionate to the impact of it, which then means that there are many things that go on that people don't pay any attention to that people should pay attention to, because it does overall collectively make an impact. And I'll give you an example of something that only happens in this country and has been happening for years, which is that every patient that gets admitted to the hospital gets a daily blood test. What is the purpose of this daily complete blood count? Will your hemoglobin change from one day to the next? But despite efforts of de-implementing it, because the cost of this CBC is so low, people don't think about the collective billions that it costs. But, for a particular health state, it's going to be a fraction compared to the other things that people will be paying for. So there's been no effort to de-implement it. But from the patient's perspective, these daily pokes, they add up to a very bad quality of experience while you're in the hospital. But no momentum because of that impact aspect.
All right, well, you better cut it there. Thanks to the panel. It's lunchtime. We'll see you back here at 1:15. There's a number of places to eat downstairs. State Street is also just a couple blocks away and tons of options there. So the weather seems to have cooperated somewhat. We'll see you this afternoon.